Thank you so much, ma. And first of all, I'm grateful to Dr. Palaniswamy for inviting me out here. Pleasure to be in Chennai. Basically, my talk would be more about there's a new concept which has come up, deep healing, like mucosal healing. The question is, should we run for it or not? And essentially, if you look at it, we think that it is really, whether it's a great revolution in the field of IBD or not. If you look at disruptive science, I have put up a slide out here which has got nothing to do with IBD. It's a beautiful infographic from Nature which shows that when did the disruptive science papers come up over last 50, 70 years? We somehow feel that most of the disruptive science has occurred in the last 2, 3 decades. That's when the web came up, that is when so many things, scientific revolutions occurred. However, if you look at this infographic, you realize that the least disruptive science has occurred in the last 2 or 3 decades. Most of the disruptive science occurred initially in 1950s, 1960s, 1970s, and we are reaping the benefit of that. So coming back to IBD now, this is the kind of, you would say, descriptive, oblique, incremental science which has taken place. That is, the goalpost has been changing. The goalpost which was initially, okay, let's just improve the symptoms. The patient should do well. Patient should be feeling well, has changed to, okay, steroid-free remission. Let's not give steroids. Steroids cause a lot of damage to having not only clinical improvement and clinical remission, but also endoscopic improvement, which is known as mucosal healing. And it has been loosely coined as, the word has been coined as deep remission. This deep remission, what does it all encompass of, has gone a little bit changed over the last 4 or 5 years. Essentially today I would say deep remission means clinical remission, biochemical remission, and endoscopic remission. And the philosophy is that deep remission is associated with better long-term outcomes. So aggressive escalation of medical therapy in terms of chasing this deep remission is probably the way we should treat IBD. And that is, let's discuss whether that is right or not. Obviously, it appears intuitively to be right because Crohn's disease is such a progressive illness. Over a period of 5 to 7 years, it moves from B1 to B2 disease and thereafter to B3 disease. A patient presents to you with inflammation. You had that case study where the patient initially presented with just mild aphthous ulcers. And thereafter, within a period of 1 year, rapidly there was progression. So obviously, if you act early, you might be able to stop the progression. What about ulcerative colitis? Does the similar kind of progression takes place? There is a progression which takes place, but that is only in the extent of the disease. It may become from proctitis to left colitis or pancolitis, something like that. Not drastically different as occurs in Crohn's disease, where it moves from an inflammatory phenotype to a stricturing or fistulizing phenotype, where the patient may have intestinal failure. So mark this fine difference between ulcerative colitis and Crohn's disease. So deep remission essentially is endoscopic and clinical remission, and this is the kind of mucosa which every IBD treating physician would want now, because that is being, in a way, it is being propelled or propagated that should be done. And obviously, if you look at the cohorts behind it, the initial cohorts were observational cohorts or retrospective data. The retrospective data showed, yes, there is benefit. If patients who had mucosal healing, they were followed up, they had less chances of surgery, they had less chances of hospitalization. This was seen both in patients with ulcerative colitis and Crohn's disease. But this is a circular argument. It's quite possible these were the patients who had a benign course. So obviously they had a lesser chances of hospitalization and surgery, and that is why you need prospective data actually to look at it. Secondly, if a patient has deep healing, deep remission, does the patient necessarily do well in real life? Well, it doesn't seem to be. This was a group of around 97 patients who were followed up, who had clinical remission, endoscopic remission, and also histological remission, the best possible kind of remission. These were patients with ulcerative colitis. When followed up for a period of a year, it was seen that still, despite that, 18% relapsed within a year, despite all of them being on treatment, suggesting that, yes, remission is good, but remission doesn't mean the patient is going to have a hunky-dory course all along subsequently. So right now, I would say this is one of the most cited studies over the last 2-3 years. This is Dan Turner's consensus study, which came up in gastroenterology, famously known as the STRIDE 2 consensus. The stride to consensus essentially says what are the treatment target today, and if you look at it carefully, you'll find that there is an immediate, initially symptomatic response. Symptomatic response is immediate. You're not looking after it at 6 months or 1 year. That is your immediate gain. The second is the intermediate, which is normalization of CRP, normalization of fecal calprotectin. And subsequently is the long-term gains is endoscopic remission and quality of life. So step by step, you want to achieve that. And if you're not able to achieve that, then you need to upgrade your therapy. Further, what you would say, work in progress is to look at histological healing in ulcerative colitis and transmural healing in Crohn's disease. So this is stride to consensus or the treat to target philosophy. So these are certain terms. There's a target, there's a term known as tight control, how to monitor, when to monitor, are the targets different? So we have initial treatment, you assess the target is, as I told you, the target is endoscopic remission, target is biochemical remission like fecal calprotectin normalization and all. And if you periodically monitor the patient and if you find the patient is not doing well, you need to upgrade your treatment consciously. It's a conscious decision that if a patient is, let's say, on azathioprine and the patient is doing well, but at the same time endoscopically not in remission, would you upgrade the treatment? And that is what this philosophy says, you should upgrade the treatment. The contenders for being a target obviously are endoscopic healing. Fecal calprotectin we all know is an excellent target. Histological healing is something which is a target for the future. So what is the evidence? Obviously the best evidence is in form of RCTs. Till now we have had cohort studies, cohort studies fall into the ambit of circular argument. So what is the randomized control data which is available for ulcerative colitis and Crohn's disease? The famous study, the CALM study, which came a few years back, which looked at patients with Crohn's disease. They were randomized into 2 arms. In one arm, they were given adalimumab, and subsequently adalimumab dose was stepped up if the patients were not achieving biochemical remission or endoscopic remission, whereas in the other arm, the regular standard therapy, that is adalimumab, was continued every 2 weekly and all, and there was a significantly higher rate of mucosal healing, which was seen in patients who had a tight control as compared to patients who had clinical management. But what is the fine print out here? This trial was only for 48 weeks. So this was data only for 1 year showing mucosal healing is superior. But what do we actually want? We want to know whether this really translates into a low rate of progression of the disease or not in terms of not getting converted from B1 to B2 or B3 or less chances of hospitalization or surgery. Comes a follow-up of the CALM study, which was a retrospective analysis, 3-year data analysis of all that came up, which showed that for 3 years, when the patients who were in endoscopic remission or deep healing, both arms, patients who had tight control and patients who were given standard therapy, both of them had a decreased risk of disease progression. So this was encouraging. Yes, for 3 years, there seems to be some very good information. So this data says that if there's early institution of biologics within 2 years in Crohn's disease, and if they achieve mucosal healing, the effect is seen till 3 years for sure. A recent abstract in UEGW 2022 further worked on it in terms of it is known as a REACT-2 study, but again, this study could not successfully find that the primary objective was whether if you have a treat to target approach, patients are going to get into remission and have a lower rates of hospitalization surgery. It could not achieve that primary objective. All it showed was if patients had high-grade degree of ulcers or if they had high CRP, probably that would be a subgroup set whereby you can go in for this kind of approach. What about ulcerative colitis? We actually do not have any randomized control data which is available for this endoscopic remission or treat to target strategy for patients with ulcerative colitis as of yet. So let's approach this question the other way. If you want to start biologics early in the course of disease, is it going to change the course of disease or not? So we have 2 or 3 good reviews on that in terms of systematic reviews as well as cohort reviews, which have shown that for Crohn's disease, if you start anti-TNF therapy early in the course of diseases within 2 years of diagnosis, it leads to lower healthcare utilization in the subsequent 5 years, whereas in ulcerative colitis, the same effect was not seen. Similarly, another study is showing that if you give vedolizumab also provides a similar kind of benefit, but only to patients with Crohn's disease, not to patients with ulcerative colitis. If you combine both of them overall, it shows that in patients with Crohn's disease, if you start biologics early in the course of disease, probably it helps. Whereas in cases of ulcerative colitis, the same kind of benefit is not seen. So let's put into a practice. I put across most of the literature which is out there. So now if you go into clinics, how are you going to do it? How are you going to do it? You have to, the philosophy is you have to target clinically silent inflammation. In other words, patient is doing well, but you do an endoscopy or you do a fecal calprotectin, it is raised. What are you going to do? Are you going to escalate the therapy, which is known as treat to target? And obviously the monitoring has to be time bound, every 3 to 6 months, which is known as tight control. What are the criteria? For Crohn's disease, clinical would be CDI less than 150. If you do an endoscopy, the endoscopy score should be, there should be no presence of no ulcers and all. And fecal calprotectin or CRP should be low, that is below the normal, in the normal limits. For ulcerative colitis, the targets are again simple: clinical remission, Mayo 0 or endoscopic remission, and fecal calprotectin less than 100. How do you evaluate it? You can, Crohn's disease, you can do a FCP or endoscopy every 6 months. In case the patient has a small bowel stricturing disease, you may have to do a imaging. There is no time period for that, but one may do a imaging after 1 year or something like that. In ulcerative colitis, it's easy to monitor, so you do a FCP or endoscopy every 6 months, and on the basis of you can decide what to do. So mucosal healing is a relevant endpoint in clinical trials, but in clinical practice, it still remains a desirable goal. Why? Because on one side, we are talking about mucosal healing. On the other side, we are not talking about the number of drugs which we are escalating. We are not talking about the issues related with the escalation of the drugs. The issues could be, one is obviously the acceptability of the patient. You would realize that some of the patients, in fact, they don't want to take any drugs at all. They're very happy with the minimum possible drugs. Secondly, is things like frequent visits and tests. If you're going to do a tight monitoring every 3 months, the patient may have to come to the hospital, may have to undergo endoscopy or colonoscopy, that is after every 6 months. Fecal calprotectin is also not that cheap. There are resource-driven factors which are out there. Besides that, the moment we move on to small molecules, biologicals, many of them are associated with side effects. We have seen that with anti-TNF when the risk of tuberculosis was very high. It was, activation was very high in our country. Secondly, the data which is there in terms of progression, stopping progression of diseases for 3 years. Crohn's disease, if it has to progress, it would progress somewhere beyond 3 years, at 5 years or 10 years of duration. It would not in the first 3 years, most of the Crohn's may not progress so much. We really do not have data for that kind of follow-up till now. So in the OPD, if a patient comes to you, Crohn's on azathioprine with minimal symptoms, and you just did a MR, and on MR you find frank inflammation which is lying out there. So the question is, what are you going to do? The patient is just on azathioprine. Are you going to upgrade the treatment or not? Let's look at whatever evidence we have got till now. Observational cohort data suggests yes. RCT, one RCT, but that suggests yes. Long-term follow-up, that RCT for 3 years suggests yes. Early institution of biologics, do they change the disease course in Crohn's disease? Yes. So are you going to push for mucosal healing in this case? Probably yes. How? You're going to review every 6 months, do a FCP, colonoscopy. Transmural healing is still a question mark, but yes, you can also check for it a year. But here you would definitely like to upgrade the treatment and move over to biologics, but be aware of drug adverse events, cost of therapy, and cost of monitoring at all. Now similarly, so this is what is like for Crohn's disease. Now similarly, if a case of ulcerative colitis comes to you, patient is on azathioprine, minimal symptoms, nothing. You just happen to do a sigmoidoscopy and you find these kind of ulcers out there. What are you going to do? Are you going to put the patient on biologics? Are we going to follow the treat to target policy at all or not? Let's look at the data. Again, we find that observational cohort data for ulcerative colitis supports it. RCT data, no, we do not have any RCT data. Do we have any long-term follow-up RCT data? No, we don't have that. Does early institution of biologics change the disease course for ulcerative colitis? No. We have good amount of cohort data suggesting no, it does not change. So are you going to push for mucosal healing out here? Probably not. And this is what I would say worldwide. If you ask the experts, they are wishy-washy about this kind of particular scenario and they try to avoid it. in the sense that everybody knows that, okay, stride to consensus is there, but at the same time, when it comes to ulcerative colitis, there's not enough data to back it up in terms of practical execution of treat to target policy for ulcerative colitis. So I think this is my final slide, that yes, practically, I told you about this. This is the practical thing to do. Theoretically, yes, we are moving now from treat to target to another new concept which is coming up, that is treat to clear. You're talking about not only endoscopic healing, but histological healing, which is already an endpoint in many of the clinical trials. And probably let's see whether we move further than that and go on to molecular healing. Thank you so much for your attention.